Hello, everyone, and welcome to the Down and Dirty Neuro of headaches. So let's go ahead and get started. Um, One of the things I want you guys to know is that we don't spend a whole lot of time talking about the difference between a common regular headache that we all have probably had the benefit of having versus a headache that belongs in the emergency department, and what kind of headache differentiations are those. So I want to spend a moment and just kind of talk about what a common regular headache actually is. So a common regular headache is usually something that only lasts about 1 to 3 hours. It's usually something that's responding to the over-the-counter medications like Tylenol or ibuprofen or Excedrin migraine. And it can have lots and lots of different causes. So you can see that I've listed quite a few there, and there's so many more than that. One of the biggest ones is if you're overheated or if you have a fever, obviously that can cause a headache. Or if you've had some kind of trauma. For example, if you've been punched in the face, probably you're going to have a headache. Or if you have a hangover. Hangover headaches, we think, are mostly caused by dehydration. Now, there's a little bit more that goes into that, but all of these are qualified under common regular headaches. None of these are going to have in any kind of like neuro symptoms. None of these are going to be emergent. None of these usually need to belong in the emergency department. Now, that doesn't mean that they don't come in, but it does mean that this is something that we don't need to scan, we don't need to do labs, we don't need to be worried about these headaches. Most common is common, right? Allergy headaches and sinusitis, that's another reason that you can have a common headache. I think you get it, right? um, the ER headaches are the ones that belong in the emergency department. The ones that are usually a lot harder to handle are the ones that are longer lasting, the ones that cause a loss of daily function. And that's one of the reasons why migraines are considered an ER headache, because they lose their daily function. And then, of course, it's something that's going to either be recurrent, severe, or non-responsive to over-the-counter medications. So this is something that's not really covered very often in textbooks or classrooms. So something that you can kind of help differentiate between the two. So always think about our common regular headaches first. And a lot of people come to the ER when they get their very first headache, not really knowing or thinking about things like caffeine withdrawal or allergies or dehydration. So you can always start with something like Tylenol or ibuprofen to see how that does before we have to do any kind of big workups, unless there's some big red flags, right? Okay, so here's a general overview sort of some of how a headache treatment goes, right? So we typically talk about analgesic overuse. You can have lots of comorbid conditions that can cause your headaches to be particularly refractory and hard to treat. And then, of course, if nothing works, they end up going to pain management, where they can get things like PT, OT, pain management, or psychiatry. And some people even do get surgery for headache that's lasted way too long. So all of that being said, this is not like a sheet to memorize or anything. Let me show you a little bit about the categorization of headaches. So most people and most textbooks will divide headaches into two types. And remember, they've forgotten about the usual everyday headache. So we have our primary headaches, which are usually just caused as a headache. There may be hard to treat headaches, but it is just a straight up headache. Whereas the other headaches listed on here are the organic headaches. And organic headaches are caused by something else. So they're caused by a brain bleed. They're caused by dehydration or altitude sickness. They're caused by trauma or glaucoma or something like that. So organic headaches are the reason why in the emergency department we have jobs. The organic headaches is what we are supposed to be in the emergency department experts of, and identifying the organic headaches versus everything else. Now, it doesn't mean that we ignore the primary headaches, and we're going to talk about those here in just a second, but I want to make sure that you understand the differentiation. And the reason why we categorize out the headaches is because our job is to ensure that these people do not have an organic headache when they go home. which means that your job is not necessarily to treat or fix their headache. And some people's headaches are not going to be treatable or fixable by the time you get to discharge. That doesn't always necessarily indicate that you need to admit them. However, we obviously want to try to do our best job trying to make our patients feel better. But as long as they don't have an organic headache, we've done our job. So please focus on the organic headaches or the life-threatening causes, right? The organic headaches, which are more rare, are the ones that we need to rule out. All right, let's talk a little bit about our organic, okay? So I just kind of said a little bit about this, that, less than 10% of all headaches are the organic type, which is why, we are supposed to be the experts of it. And it's really important to know at least the main 3/4 headaches that you cannot miss. And the number one is a head bleed. Head bleed headaches are probably one of the most litigious areas of headaches in general. We do not want to miss a brain bleed headache. And we're going to talk a lot about those here in this lecture shortly. You also don't want to miss meningitis. Meningitis is the number two most common malpractice case in headaches besides head bleeds, because if you miss meningitis, they're going to die. So please always think, is it a head bleed? Is it meningitis? And then the last area is glaucoma, believe it or not. Remember that not everybody will come in complaining of eye pain. That's going to be something that you're going to always have to get used to doing, is the eye exam in a headache, okay? And there's tons more in here. We're going to go through a bunch. So here is a pathway that I got from a website for headaches, and you can kind of work your way through it if you're somebody who really likes the pathway protocol. This also helps you decide whether or not this is a headache that needs a CT scan or an LP or something like that. And it kind of helps you go through some differentials. I'm not a chart person, I guess, although this can be easy to look up later. So let's move on from here. One of the big factors in discussing headaches is all about the red flags, and knowing what is a red flag, what is an indication of that organic headache versus what is not. So if you're a mnemonic person, a lot of websites and books use the SNOOP mnemonic. So pretty much if you're having systemic symptoms like a fever or abnormal neuro symptoms, if the onset is thunderclap or brand new or changed in some way. And then of course there's a previous headache with some kind of change. And then there's the orbital headache, which is usually something that we need to think about glaucoma for. If they're obese, that's going to be like a pseudotumor or intracranial hypertension, as they call it now. And then if they're old, so the elderly are going to be more common to get some sort of like subarachnoid hemorrhage. So that's the SNOOP mnemonic. I think we've kind of gone over quite a few of these risk factors, but one of the things that I'd like to bring up that's not included in the SNOOP mnemonic is anticoagulation or the pregnant and immunocompromised patients. So those are two big areas that have really high red flags, really high risk factors that we don't want to miss. Most people with anticoagulation, especially if they've fallen or having some kind of trauma, most of us know to go ahead and order that CT scan to rule out the head bleed. However, it is something to think about. If the anticoagulation is, like, let's say their INR is over 10, that's when people start getting spontaneous bleeds. So you don't necessarily always have to have trauma. Just being on anticoagulation makes your risk that much higher. Same is going to be true about people who have recently had TPA for things like stroke or heart attack. I'm sure you guys can work your way through that. And I'm going to move on from this slide, sorry. So when do we need to get a CT scan, a CTA, an LP, or labs? Now, I want to let you know I'm going to talk about a little bit more than just these four a little bit later on. But when do we need to get a CT scan? So it's really important that you know that not all headaches deserve a CT scan. So again, it's really important that all headaches get a neuro exam, which we'll talk about shortly. But not all headaches need a CT scan. So you want to pay particular attention to signs of meningismus and neuro symptoms, especially within the first 6 hours. So if somebody has an abnormal neuro finding, you need to be ordering a CT scan. Or meningismus, right? If that's something that you're going to be doing an LP for, you need to get a CT scan. A CTA or CT angiogram is when you're looking specifically for a dissection or clot. So dissections aren't always in the aorta. You can have carotid dissections, you can have vertebral artery dissections, and you can even have dissections of the blood vessels in the brain. You can also have clots in the blood vessels of the brain. And you have to pay particular attention to the onset of the headache and the sex of the patient. So females are way more likely to have dissections and clots, and onset is going to be usually with some neck pain, or we'll talk a little bit more about the onset later. LPs are something that you need to pay attention for fever and meningismal signs. And then you also need to pay particular attention to a papilledema patient, right? That's our pseudotumor or intracranial hypertension patients. That's when you need to do an LP. So pretty much just meningitis versus papilledema. So if those patients don't have those signs, then they don't need an LP typically. And then finally, labs. Labs are actually really unhelpful in most headaches. Let me say that again. Labs are really unhelpful in most patients. Even people who have terrible organic causes of headaches usually won't have abnormal labs. The areas that labs are most helpful is going to be in your pregnant patient, because we want to rule out eclampsia or preeclampsia or HELP syndrome. And then also in our toxicology patients. So somebody who maybe has had an overdose of something. And then the last but not least is the people who are on anticoagulation. And I know I don't have that listed on the slide here, but obviously you probably want to get an INR if the person is on warfarin. Now, of course, a lot of the newer agents don't have labs that we can check, but that would be an indication that we care. The last part of this is going to be, well, why isn't meningitis listed as something that we would need labs for? And the answer is because you don't need to wait for labs to start suspecting that this person has meningitis, right? If the person has a fever, you don't need a CBC to tell you that you're suspecting infection, right? Regardless of what their white blood cell count is, are you still going to do the workup for meningitis? Are you still going to treat them with antibiotics? Yes. And that's why I didn't include fever on the lab work area. So let's start with talking about our primary headaches, because that is our first area that we can get out of the way. So there are 4 main types of primary headaches, as you can see here, and tests love testing your knowledge and your classification of all these different kinds of headaches. So it's really worth your time, energy, and effort to understand the differences between all these types of primary headaches. These always make for easy test questions, and technically, they have different areas of pain. They have different qualifications of pain. So for example, migraines tend to be throbbing, whereas tension headaches tend to be a band-like area around the head. Now, this always occurs, at least in test questions, to give you signs and symptoms to help you identify each type of primary headache. I think this is worth your time to study for tests, but I also want to let you know that in the emergency department, can you have a migraine headache that is bilateral and throbbing and also tearing? The answer is yes. So in real life, these are not as clearly delineated or divided as they are in tests. So I do want you to be aware of the differences between real life medicine and test medicine, because these can get very, very blurred. That's why we tend to treat most primary headaches with the same kind of cocktails that we treat migraine headaches. And again, we're going to talk a little bit about that as we go through this lecture. The end headache here, the sinus headache, is something I'd like you to pay attention to in general, because I feel like the sinus headache is probably the only one that I can differentiate between all of the other ones with some regularity. And sinus headaches can usually be treated by treating sinusitis or having people do nasal rinses and that kind of stuff. So sinus headaches are good to identify because the treatment is slightly different, but the rest of them, we typically almost always do migraine cocktails. So let's talk a little bit about headaches happen. So I do have to let you know that while the pathophysiology of a migraine is something that's included in a lot of textbooks and it is something that's talked about, it is actually only a theory. We don't have proof of this yet. We just have a lot of things that make sense more with this particular theory. So what happens is we have some blood vessels in our scalp, and those blood vessels, for one reason or another, start having a vascular spasm. Think very similar to Prinzmetal's angina in the heart. And because those blood vessels are spasming, some area of that blood vessel clamps down for some reason or another. That causes decreased oxygen to the area of the scalp that is a lot distal to that vasospasm, which causes the muscles to then spasm and get angry. And that causes more tension. And then that causes our pain receptors. Now, you know that the scalp is located on top of the skull, but it is related right there, right next to the brain. And they do share some veins. So when they're spasming and they're really angry, they're releasing all of those prostaglandins and all of those cytokines and all of those angry inflammatory chemicals that irritates the brain, and it's going directly into the brain using those veins and the blood system, right? So that's causing it to spread over the brain and get to the brain so fast that that's what we think causes the headache. Now, obviously, a lot of different people have different ideas on which nerves are involved. Some people talk about the trigeminal ganglion as being the main center to identify what's happening and to cause the headache. But regardless of which nerves they are or anything like that, it's really handy to know how this headache actually comes into being, because we can use that to our advantage when we're talking about treatment. So a lot of people talk about whether it's a migraine or not a migraine. You can have your typical nausea and vomiting and your photophobia and phonophobia, but remember that we treat in the emergency department some kind of headache, primary headache, as migraine almost all the time. So it doesn't just have to be a throbbing or a pulsing headache. It doesn't usually have to be unilateral. I've seen plenty of people with bilateral headaches get better with a migraine cocktail. So let's talk about these migraines. Notice that I've included on here a big table of possible triggers for migraines. Knowing and being able to educate your patients on the triggers for their migraines, especially if you're seeing them recurrently, can sometimes really help them prevent further ER visits with your migraines. So I see migraines particularly most commonly in females, although males can have them. Usually migraines start around teenage years, and some people in families tend to be more likely to have headaches. So if your mom has migraines, then it's possible and more likely that you will have migraines. But we do know that migraines can be linked, especially in females, to hormone therapy. And that doesn't mean that you're always on oral contraceptives. That could mean that your body just produces more or less hormones, or you're more sensitive to hormones. And so a lot of people develop migraines either right before, on, or after their cycle. This can be one of the biggest causes. So it's always a worthwhile question to ask the female if she's on her cycle or just finished her cycle. And this is actually a contraindication to giving people oral contraceptive pills, because they can get so many headaches. They can come to the ER quite often that they may need to switch their oral contraceptive pills because it's either too high of a concentration or can cause more problems. Remember that this is all about meningeal inflammation, and migraines are really tough because we have the typical unilateral pulsing, throbbing, photophobia, phobophobia. I probably said those backwards. Sorry about that. And then of course, the nausea and vomiting. When you kind of identify your typical classic migraine, you can talk to people and they'll say, well, the only thing that makes it better is if I lay down in a dark room. and I don't move around a lot. And therefore I can't go to work, and I can't do my daily activities, which is one of the reasons why in the ER we need to address their migraine. Notice that there's a ton of other triggers though. Alcohol consumption is one, changes in weather, air pressure. We see that a lot down in Houston. And then of course there's certain foods, including chocolate, wine, and cheese. Those are foods in particular that can definitely be the cause of a migraine, but so can nitrates. Remember that when we give nitro sublingually for a heart attack, that can cause a lot of patients to have migraines. It's almost always a side effect. So any other nitrates can also cause migraines. You can see down here that there are 2 blue boxes, and those blue boxes are how the neurologists divvy up migraines. So they divvy them up as a classic migraine, which is somebody who usually has some kind of warning that the headache is coming on. They call that an aura. So a classic migraine has an aura. A common migraine has no aura. I'm not exactly sure why they divvy these up into different boxes, especially because we treat them almost the same. But a lot of neurologists, especially if you're calling them to talk to a patient about their migraine, it's really handy to be able to use these terms with the correct definition. So you have the common migraine and the classic migraine. Here is a general picture of the 4 stages of migraine. And remember that nobody reads the book. I've seen a lot of variability in these migraines, so not everybody follows this path. What I'd like you to really pay attention to in this picture here is that while they may or may not have a prodrome or an aura, and they may or may not be aware of that prodrome or aura, notice that it's not lasting very long, and that the migraine itself lasts up to 7 days. So even though this particular picture only says that the migraine attack lasts from 4 to 72 hours, that's not always the case. Some people have migraines that last days or weeks, and some migraines will stop for like a couple of hours, and then they'll happen again, and they come in waves. So it is important to understand that migraines are pretty debilitating, especially the classic migraines with the aura. And so have a little bit of compassion with this and understand that sleep is a problem, and that you can get a lot of these abnormal symptoms that some people accidentally think are neuro symptoms, like the tearing or the sinusitis or the anxiety or the giddiness that sometimes comes with migraine. I do want you to be aware that there is something called a complex migraine, which is any kind of migraine headache with a neurosymptom involved. Several textbooks that I've seen have called these hemiplegic migraines because they believe that it's occurring in one side or a particular area of the brain only, and they relate these specifically to your genetics. But that said, any kind of headache with a stroke-like symptom or a neurosymptom is considered a complex migraine. These are more important to do a little bit bigger of a workup on. Remember that this is going to be a diagnosis of exclusion, and it's typically not an ER diagnosis. Typically, these are some people who are coming in saying, oh yeah, I already know I have complex migraines. It's already been established. I already see a neurologist, that kind of thing. That complex migraine is not something that we diagnose in the emergency department without the help of the neurologist. There is something that gets tested quite frequently called Todd's paralysis, and that is a complex migraine that has been specifically documented with an inability to move a limb. So a lot of people think that it looks like very like stroke-like, and it can happen after seizures often. So that's another thing to just kind of be aware of. And the last is a vestibular migraine, which is a specific named complex migraine. Vestibular migraines are headaches that always occur with very impressive dizziness or vertigo. Like they have a headache, and then they can also not walk down the hallway without like running into things or throwing up, that kind of stuff. So let's talk a little bit about the medications that we can use in the emergency department. So there are quite a few medications. Now, I want you to notice that this list is a lot different than maybe the ones that you'll see in your textbook or the one that you learned in your neuro class, because when we talk about migraine medications, a lot of the neurology medications are used to prevent headaches, not treat headaches. So when we talk about headaches, primary headaches specifically in the emergency department, we want to break the headache cycle. We do not necessarily, we're not in the business of preventing the headache. And that's why you probably aren't going to see sumatriptan used very often, because while it can help break a headache, it's primarily used for prevention of headache. Okay. So in the emergency department, a lot of these have been really heavily studied. So let me tell you a little bit about some of the common migraine cocktails in the emergency department, and then which ones are best for when. So the typical migraine cocktail is going to be a Toradol IV, which is an NSAID. And then you're going to have some kind of use of either Reglan, Phenergan, or Compazine. And you're going to notice that all of these are antiemetics. So you don't use all three, you just pick one. And these are nausea medicines, but they work to break the headache in combination with Toradol. Now, a lot of colleagues that you're going to go out into the world and notice are going to also use Benadryl. And some people use Decadron. Everybody uses IV hydration, so they always give a bolus of fluids. Some people almost very frequently use opiates. But as far as the efficacy of a lot of these medications go, some work and some don't. So these are the ones that have been disproven. So opiates are almost always the worst to give to people with a real migraine. So when the medicine is given, they say it helps. And then when they go home, the migraine is almost always worse when the medicine wears off. And so in general, it is a really good practice to not use opiate medicines for headaches, migraines in the ER. If they have that bad of a headache, then they need to be seeing neurology. And I can guarantee you that if they keep up to date with anything, neurology does not use opiates for any migraines. Next is IV hydration. So this is kind of a myth going on in the emergency department, but giving fluids isn't really going to help your migraine unless it's caused by dehydration. So things like hangovers and that kind of stuff. So while it doesn't necessarily hurt, it also isn't really helping. So this is something to know, that if they're presenting with a classic migraine headache, you don't need to give 1 liter bolus. You don't. And then Benadryl. A lot of people don't actually know why we use Benadryl for headaches. And so it's something they just see the attendings do all over and over. And so they just start doing it also. Benadryl is given classically not for the headache, but to help combat the side effects of one of the medicines, of the antiemetic medicines. So I have a lot of colleagues who use Toradol and Reglan. And Reglan has a lot of side effects, like the dystonic reaction or tardive dyskinesia, that kind of stuff. So in order to prevent that prophylactically, instead of just giving Reglan, they give Reglan and Benadryl. So that way they're treating the side effect of Reglan already. So the Benadryl isn't actually to help headaches. And it has been exclusively proven in many studies, I challenge you to go look it up, that Benadryl does not help with headaches. So I don't give it. I'd also like to point out that a lot of these studies have been showing that these three medicines are 100% proven to make a big difference in migraine headaches. So these are the medicines that I'm personally using. However, with the studies that have been shown, Compazine, Phenergan, and Reglan, Compazine almost always comes out on top over the other two. So whenever possible with a migraine headache, give Toradol and Compazine. Then you won't need to give Benadryl, right? And then if need be, you can also give Decadron. The Decadron is usually given IV, and the whole reason is not to break the headache, it's to prevent rebound headaches. So when the meds wear off, when that Toradol and Compazine wear off, then you're going to start noticing that people will come back in several hours later because they'll start having a rebound headache as the meds wear off. Decadron has been shown to prevent the rebound headache. So to prevent that headache from happening again tomorrow and the next day. And so our goal in the ER is to break that cycle. And so Decadron has its place, specifically if the patient is not diabetic. So don't forget that diabetics are going to have an increased glucose. So we want to be careful in giving Decadron to our patients with diabetes. Now, I do want to make a mention here before we move on about Phenergan. While Phenergan isn't as good as Compazine, we had a national drug shortage of Compazine for a very, very long time. And Phenergan is particularly cheap. It's on the $4 list at Walmart, at least it is this year. And that's an important thing to know because a lot of our uninsured patients who are chronic migraine users of the emergency department who cannot afford medicines like sumatriptan can be given a prescription for oral Phenergan as a migraine headache medicine. Now, is it the best? No. Do our neurology colleagues do that? No. But it's better than nothing or ibuprofen, and it can be used for our patients who do not have insurance. Something to consider and something that is worthwhile if you cannot get a hold of Compazine. I use Phenergan frequently. Okay, next is these last three medicines, which is the sumatriptan, which you notice I put a big yellow question mark right next to because it can help if you give it to them IV within 6 hours of onset. But timing here really matters because a lot of patients, they're not coming to us within 6 hours. A lot of patients come to us days later after they've tried everything, or they come to us in the middle of the night after a 24-hour period of headache. So the number of times that I have used sumatriptan in the ER is very low, not just because of the timing, but also because it has a lot of side effects that a lot of ER providers are not very comfortable with. So I want you to make sure that you understand that you can give it and that you got to do it within the 6 hours of onset where it's almost entirely useless. So I don't see sumatriptan being used a very lot in my ER. But of course, it's not wrong to give it. And then the last two meds are meds that I got from some of my neurology friends after seeing people with headaches be consulted over and over and over and over. Magnesium IV is something that has been shown to work. It's supposed to relax the smooth muscle walls of the vasospasm that the headache has, that kind of initiated the headache. And usually we're giving 2 grams IV, and that's only in refractory cases. But I have seen magnesium work, especially for some of the patients that were getting opiates before, and now instead of giving opiates, they're getting IV magnesium. However, in studies, magnesium and caffeine haven't really been shown to be 100% efficacious, not necessarily because they're bad, just because we haven't spent a lot of time studying those specifically. Caffeine, we know, works in post-LP headaches, which we're going to talk about here a little bit, but caffeine can also exacerbate headaches just as much as it can help headaches. So you have to be careful in who you use these caffeine pills in. Typically, you want to give something around at least 60 milligrams for it to be effective. However, fun fact, that caffeine works specifically in not just the headaches like post-LP headaches, but it's also really good for concussion headaches. And the difference between Excedrin and Excedrin migraine over-the-counter medications is just caffeine. Literally, Excedrin migraine is the regular Excedrin with a little bit of caffeine in it. So if it was working well for over-the-counter medications, then it might be something worthwhile to use with us. It's also a medicine that's used in something called Esgic or Fioricet, which is another medicine that we use and give very commonly in the ER just as a as-needed basis for patients who have insurance, who can afford medications to break their headache and not come to the emergency department. So definitely, if you're having a refractory headache to somebody who you've given Toradol, you've given them Compazine, you've given them the Decadron, and it's not working, you can always try IV magnesium or IV caffeine. Here are a lot of other medications used in migraines. I'm sorry, it's kind of blurry. We had to take a picture of a textbook, but what I want you to see is that we don't use a lot of these medicines that are listed here. You can tell that this textbook is a little bit older, but a lot of medicines are used to prevent attacks rather than to treat them. And a lot of them are dependent on triptans, which only work within the first 6 hours. So I think you can figure it out from there. Now let's move on to cluster headaches. Cluster headaches are very multiple, intense, back-to-back headaches. We don't 100% understand cluster headaches, but we do know that they have been going on for centuries. We do know that there tend to be men who experience cluster headaches, and that they've been so bad that cluster headaches are the highest headache to cause suicides in patients who have recurrent headaches. As you can see from the picture here, it tends to start in one particular eye. This one is unilateral, and it's almost always involving, you're going to see red conjunctiva, tearing, maybe even swelling of that eye. And cluster headaches are almost always exacerbated by alcohol. Not that alcohol is required to get a cluster headache, but these definitely wake you out of sleep. They can drive people crazy. People can even come in even after the headaches have stopped, just because they've occurred so many times that they're afraid to go home because they're afraid for another headache to have happen. You can see here that the treatment is 100% oxygen, although typically we're giving people the NSAIDs and steroids that we give to most headache cocktail patients. It's really important to tell these patients that they cannot drink alcohol, that this will happen again. And you can consider some anti-seizure medicines for prophylaxis that are typically recommended by our neurology fellows. So valproic acid or Depakote, gabapentin, or verapamil are all good medicines to prevent, although that should be given only in tandem with a neurology approval. So our tension headaches, this is our number 2 most common type of headache. I feel like tension headaches and migraine headaches kind of blur together quite a bit. But tension headaches are almost always caused, instead of by vasospasm like the migraine, it's usually caused by some kind of muscle tightening or straining. So if you have enough tension being pulled on your scalp muscles, eventually that's going to initiate the prostaglandin and inflammatory process that the migraine pathway did, and then we're going to get the same kind of process. These are usually called the stress headaches, right? Because if people are really experiencing that much tension or stress and unconsciously sort of clenching their muscles or whatnot, that's what's leading to their headaches. This is one of those headaches where you want to really talk to them about lifestyle modifications and kind of distancing themselves from stress whenever possible. Not all of these headaches are going to have the nausea or the photophobia like migraine headaches will, at least not within the first 24 hours. These ones can also be caused due to lack of sleep, right? So when we're not sleeping very well, we tend to not handle stress as well. And we've seen a lot of increase of tension headaches in our millennial population due to screen time. So you got to pay attention to those kids or those teenagers and middle adults if you're spending a lot of time in front of a screen that is inducing our tension headaches. So you can see here that the treatments for these are particularly related to trying to get people to relax. I have seen some people even give muscle relaxers to these patients, as well as like Toradol and the magnesium. Those tend to help these patients particularly well also. Tension headaches respond really well to suboccipital nerve blocks or occipital nerve blocks. So you notice here that there's quite a few people that recommend things like exercise, cleaning up your diet, starting with stress reduction. Almost all of these sort of like wholesome headache therapies are related towards tension headaches and stress reduction rather than migraine headaches or cluster headaches. So that is something that you should be aware of in some of the mainstream medical advice out there. These occipital nerve blocks are particularly effective in tension headaches, especially ones that are refractive to medications. And they're one of the easiest nerve blocks that I do. I highly recommend that you at least look at the link that I've included here if you have the chance, because, or even go to YouTube and type in occipital nerve blocks, because these are really, really effective and they're really easy to do. They have almost very few side effects. Just get a little bit of lidocaine, about 1 cc, and inject it into the side that's causing the headache. And usually it works within about 20 minutes. All right, so this is just a review of all of those different kinds of headaches. Notice that we didn't talk too much about sinus headaches because you already know what to do with sinusitis. You already know that nasal saline rinses are going to help, and so are things like Afrin and that kind of stuff. So I'm not going to go through the sinus headaches. Here are a couple of alternative headache treatments that I do want to talk about a little bit. These are a particular area of interest for alternative medicine users because they tend to work and we're not sure why. Probably has something to do with the fact that these are in response to some kind of vasospasm or accidental nerve firing. But we've already talked a little bit about suboccipital nerve blocks. That's become more mainstream than it is alternative, although it used to be alternative and it has been proven to work. We also talk about a little bit about tender points, where you squeeze that area in between the index and the thumb area, and you have to push on it really hard in that thenar muscle there. And that has been shown to help with headaches. Again, we're not sure why. And then of course there's acupuncture or chiropractic for headaches. And again, there's been a lot of legitimate studies that shows that it's efficacious and better than placebo. However, we're not really sure how those work. So that is something worthwhile if your patient is trying to combine that with regular medical therapy. All right, so now we are finally going to get into the organic headaches. I have a couple of different ways to organize these listed on the screen here. In a lot of textbooks, I guess, victim is the way that people remember the organic headaches. So again, if you're a mnemonic person, victim is a good way to remember all the different organic headaches and to go through them in your mind. I like actually organizing them in a different way, and that is actually the cause of each of the headaches, because I think that that helps me try to figure out how to treat each kind of headache. So let me show you a little bit about my organization. So you'll see that there are a lot of headaches that are caused because of increased intracranial pressures. Things like tumors, things like pseudotumor or hydrocephalus or a blood clot or a problem with a post-LP, right? So if your intracranial pressure goes down because of that LP, that's why you have abnormal headache, right? And then I kind of pulled out of increased intracranial pressure a subcategory, which is head bleeds. That can also cause headaches. And so particularly for your intracranial pressure headaches, even your head bleeds, one of the factors that you need to be more aware of is the headaches change with position. That is my big secret key factor. So if I'm talking to this person and they specifically are mentioning, without me prompting them, that certain positions seem to make it better, so they're better laying down or they're better standing up or that kind of stuff, then I'm always thinking this could be an organic headache, and I got to think about my increased or my changes in ICP. And so I go through that thought process if people mention positional. Now, the other one here is toxins. So we already know about caffeine or carbon monoxide, hypoglycemia, that kind of stuff. Those are almost always revealed by labs or history rather than anything else. So those are going to be the rule out kind of headaches. And then we have the, oops, sorry about that. And then we're going to have the headaches that are caused by infection. So one of the things that's going to make these different is that they're going to either have a fever or a high white count. And remember that we don't always have to get labs for these patients, but if you have meningitis, dental abscess, some sort of head infection, you know, I've seen people with like an abscess on the face or something like that, that can lead to headaches, sinusitis, some sort of infectious inflammatory prostaglandin situation happening. That's going to be a cause of organic headaches. And then the last little category here is those that are caused by oxygen deprivation or oxygen issues. And that's almost always going to be something that was found in the history. So you always got to ask questions about things like high altitude, low altitude, low blood volume, which needs some fluids, right? That's dehydration essentially. But the cause is if we have low blood volume, we're not getting enough oxygen to our brain, and that's causing us a headache. Obstructive sleep apnea is a good example of that. Those people have headaches very often. And then nitro is a really good example of that also. So this is why I don't use the mnemonic. I like to separate them out and try to figure out what specific thing I need to be asking about. So that means that in all patients with headaches, besides asking them if they're nauseous and vomiting, or if they have blurry vision or, neuro symptoms or findings, I'm asking them about positional changes. I'm asking them about fevers or infectious etiologies. I'm asking them about, travel history or taking any new meds or any kind of dehydration. And then I'm also asking them about drugs and intoxication stuff. So that's kind of my workup, and that kind of helps me try to figure out where to put them in my headache categories. Now, I do have to go ahead and address some myths here. Hypertension does not, I repeat, does not cause headaches. I know your mind was just blown, but usually if you have high blood pressure, your high blood pressure is going to be hitting the top of your blood vessels in your brain. And we're worried about things like that high blood pressure getting to be stroke level and causing one of those blood vessels to break and then you to bleed into your brain. So hemorrhagic stroke is what we're worried about when your blood pressure is really high, like in the 200s. And we did talk about this in the cardiopulm section, but I want to reiterate it here, that if your blood pressure is 200 or 250 over 100, that one time or 1 hour or 2 days is unlikely to rip that blood vessel unless that blood vessel is already stretched and already causing a problem, right? So if you already have an aneurysm, that's a scary thing. However, if your aneurysm has been fixed, or if you don't have an aneurysm, then hypertension doesn't cause headache after just 1 day, because there is no brain bleed, right? So this is a big myth. It keeps getting perpetuated, and I'm not really sure why. So when you go for a run, if you've not been a runner and you run a mile and then you take your blood pressure, which I don't really recommend, your blood pressure is going to be like 250 over 100. And yet you don't have a headache. That's because you don't have a brain bleed. And that may be because you're young, or maybe people say, well, that's because I'm not old, but that's not the case. That high blood pressure temporarily is not going to cause a headache. There is one exception to this rule besides the hemorrhagic brain bleed, right? And that is something called PRES, posterior reversible encephalopathy syndrome. This is something that's particularly rare, and it's hard to find, and it's related to your diastolic pressures. Because if your high blood pressure is high enough for long enough, so we're talking months, not a couple days, then eventually that beatdown of your blood vessels is going to cause brain swelling, and that is what causes the headache. Now, remember that eventually, if your blood pressure stays high enough for long enough, again, a couple of months, then eventually it's going to lead to an aneurysm. And eventually you are at risk for a brain bleed. So I'm not saying that hypertension is something to ignore, but I do want to make it extra clear that hypertension is not the cause of an acute headache. Important for you to know. All right, let's talk about brain bleeds. All right, the most common cause is trauma in sports. So always ask people, hey, have you fallen? Did you hit your head? Or have you had a concussion? If you have a person who had any of these things, you might need to talk about doing a neuro exam and paying particular attention to whether you need to do a CT right now or not, right? People who have brain bleeds typically are going to have some sort of sign or symptom. If they have a life-threatening brain bleed, they're probably going to have had a seizure, a loss of consciousness. They might be nauseous or vomiting. They're going to have neuro findings. This is not going to be a little thing, right? Except in certain patients, right? Remember that the brain tissue is insensate, which is lucky, because if somebody pushes on your brain, you actually can't feel it. But the meninges, or that dura around the brain, that's what feels uncomfortable. So if the meninges get swollen or if they get pushed on, that's where we start getting some sort of visceral response. The big thing that everybody worries about with headaches and brain bleeds is usually a subarachnoid hemorrhage. Usually that is related to some kind of spontaneous ruptured aneurysm. So that really involves a history of long-term high blood pressure and maybe even a thunderclap onset. So this is something to pay particular attention to. Always ask about onset and always think about, have they had high blood pressure for a very long time? That makes them way more likely to have a spontaneous subarach. The end game for all brain bleeds in the emergency department, if you happen to find one, is to call neurosurgery. If your hospital or wherever you're at does not have neurosurgery, that patient gets transferred immediately to somewhere that does. That's pretty straightforward. Here is this end-all be-all slide of brain bleeds. These are the 5 main kinds of brain bleeds and example pictures of all of them with really helpful red arrows. Yay. Remember that brain bleed headaches are going to be positional. So that means that there's going to be worse with changes in position. And that is something that you can do and be really mean in the emergency department, is you can take them on their stretcher and have them stand up or lay down really quickly and see if that changing of the blood volume changes their headache, right? If you're standing up versus sitting down, that's changing your intracranial pressure and your blood volumes in your brain just enough that it's changing the headache. Now, CT scan, this is important. CT scan is the most sensitive within the first 6 hours. So it's almost so good within the first 6 hours of detecting a brain bleed that we don't do LPs with a normal CT within the first 6 hours of a headache. Let me say that again. CT scan is so sensitive within the first 6 hours of a headache for brain bleeds specifically that we don't have to do an LP to rule out a subarachnoid hemorrhage anymore or any kind of brain bleed because the CTs are so good. Now, this may not be true in some areas of the world where they don't have the brand new CT scanners with the thin slice and all that kind of stuff. So if you have an old CT scanner that's only getting like 5 or 6 images, maybe that's not as true anymore. But the main differences here of all the different kinds of brain bleeds, you can see intraventricular is probably going to be one of the most obvious brain bleeds, because intraventricular, whenever there's blood inside the ventricle, these people are usually vomiting like The Exorcist. Then we have intraparenchymal, which are usually causing a lot of high blood pressure and a lot of headache. Subarachnoid is probably the most subtle besides subdural. Those two are probably some of the most subtle to find. And then, of course, we have epidural, and that's almost always going to be surgical. Of all of these brain bleeds, some of the big differences is elderly are more likely to get a subdural because the bridging veins and the brain atrophy that's caused inside your skull is causing most likely a subdural bleed because they're so fragile and easy to break. Epidurals, which is a arterial break inside your skull, epidurals are more common in the young and the trauma, right? So epidurals, it's not saying they can't ever happen in other patient populations, but epidurals are way more likely to happen in the young because the young don't actually have a whole lot of space inside the brain. They don't have the atrophy that the elderly people do to allow some rustling of the brain. And then subarachnoid is usually related to hypertension and a pop of an aneurysm. So you want to pay particular attention to the blood pressures and the history. Intraventricular, I've already told you, they are kind of vomiting like an exorcist. And interparenchymal usually have some sort of AV malformation or tumor associated with the bleed. And these people usually have extremely high blood pressure and they've never had high blood pressure before. The final thing I want to say about the slide is that blood on the brain can cause vasospasm and seizures. So if people have a seizure for an unknown cause, it's always really important to have it in the back of your mind, a possibility of a brain bleed. And people with big brain bleeds, we usually give a medicine called nimodipine too, because what that's going to do is that's going to prevent that blood from irritating the blood vessel and causing the seizure. So we're actually giving nimodipine to prevent vasospasm and seizures, which are very common within the first 96 hours of brain bleeds, particularly the big ones. All right, now identifying the brain bleeds on CT scan is something that is frequently tested, and for some reason, I tend to get really confused about. So I wanted to go through a couple of quick, simple, fast slides to show you some differences. So the difference between a subdural and an epidural. So we already talked about subdural being a venous bleed, and usually it's in the elderly. Usually it's due to brain atrophy or on anticoagulation. Usually only takes trauma like I fell down to cause a subdural bleed in an elderly patient. So notice that it looks like a banana on the CT scan. So that means it's crossing suture lines and it's like lining the dura. So it's on the outside of that dura mater that we talk about inside the brain. And if you don't know what I'm talking about, you should definitely Google it because it will help you understand this. Epidural is below the dura, sort of, and it looks more like a lime or a lemon because it is a sudden, quick arterial bleed that fills up and pushes on the brain, and it doesn't cross suture lines. We often think about epidural bleeds as people who have experienced trauma. They're usually young, and then they have this transient loss of consciousness. So when it first happens, they're awake and they can tell you what happened. And then all of a sudden they lose consciousness, and then they come back to consciousness, and then they lose consciousness again. So that kind of going in and out of consciousness makes it really high likelihood for epidurals. Those are the ones that you only have a few hours to prevent brain herniation and death. So you want to be really, really careful with those epidurals. You want to know what that looks like. Then we have, of course, our subarachnoid hemorrhage. And this is another one of the three that you need to recognize. It's the starfish. So you can see the white starfish in this scan. This is usually some kind of ruptured aneurysm or AVM like we talked about. It's usually ram, bam, sudden, rapid onset, severe headache, worst of your life. And usually they're going to have a history of high blood pressure. There is a bunch of different decision rules out about subarachnoid hemorrhages. The problem with a lot of these rules that I want to point out to you is that if there's a whole bunch of different obvious causes like new neurodeficits or recurrent headaches, you can't use a lot of these rules. So far, most people haven't really decided on a rule that they like to use because the bottom line is it has not a lot of benefit in identifying patients who because of the low specificity, right? So that means it's a high sensitivity, but a low specificity. So it can rule out, but not rule in, if you will. So there's that. If you're somebody who really likes having these rules, you're more than welcome. This is probably the most studied one out there right now, but they're always coming out with new decision rules. Now we got to talk about post-concussion syndrome. This is the only slide I'm going to talk about this. But after you have a concussion, right? So you've had some kind of trauma. Maybe it's a football injury, maybe it's sports, or maybe it's an elderly person who fell down and hit their head. After a concussion, which is a brain bruise, essentially, you can have a headache. Usually it lasts about 24 hours, but it can last up to months after the headache. And you start having symptoms that belong, one symptom in at least all four categories. So there's some kind of like mental fog or remembering issue. And then you've got either some kind of headache or nausea and vomiting or lack of energy, kind of a physical symptom. And then there's some kind of mood changes going on and a sleep disturbance. So if you can think of all four of these circles as at least one thing in each, you probably have post-concussion syndrome. The hard thing about post-concussion syndrome is, aside from caffeine, which we talked about earlier, there isn't a whole lot of things that help post-concussion syndromes. This headache and or this syndrome doesn't really improve. It's just your brain having to reabsorb that brain bruise, and how big or terrible that brain concussion was will determine how bad your post-concussion syndrome becomes. You can see here that I've included the WHO criteria for a concussion and what the definition is, just in case you haven't gone through that lecture yet. Oh yeah, I wanted to tell you my secret for post-concussion syndrome, especially with football players, which always makes moms laugh. But Midol, which is typically used in females for their cycle, is something that is Tylenol, caffeine, and diuretic. And Midol is something that we use in post-concussion syndrome frequently because it's Tylenol for the headache, which may or may not help. The caffeine, which is needed in the post-concussion syndrome, and then a diuretic together. So a lot of trainers and a lot of folks will give patients with post-concussion syndrome Midol. So you'll see a lot of football players who have Midol in their bag. Something fun to know about, and you can definitely use. Now let's go into our vascular headaches. I like to teach vascular headaches by example cases because it's a lot easier to kind of explain the differences. So I'm going to let you read this, and then I'm going to point out what I think are the most important pieces of this. Okay, so one of the things you got to notice is that she's post-op day 16. So that means she had some kind of surgery. As you continue to read, you find out that she's actually just had a baby. So 16 days ago, she had a C-section delivery, it looks like, and now she has a headache. It looks like it's been ongoing for at least a week. And she says it's different than usual migraines. So already we have some concerns. She's had surgery. She was pregnant. And this is worse than her previous migraine headaches. Those are already some big red signs. Now as we go through here, we do notice that she has no neurodeficits, and she hasn't had any. And last time she was given Reglan and her headache resolved. So that's great. But now her headaches come back again. And today we found that she does have a neurosign. She has expressive aphasia. Plus, she has eye redness. Now, to me, this is going to be something that needs a CT scan, but the CT scan is going to be normal. And of course, it's going to be normal because CT head that we usually do, CT head without, what we're actually looking for in a without scan is a brain bleed. And she's not describing to me a brain bleed. She's describing to me what I would guess is a brain clot. So what you're seeing here is an MRI of a sinus cavernous thrombosis brain clot, which can lead to eye swelling and headache and neurosymptoms. And it's usually waxing and waning. So this is a cavernous sinus thrombosis. So you can see that the eye swelling can be really intense or may just be a little bit of redness. This is where the cavernous sinus is located. It's actually right in the middle of the eyes, right behind in the center there. And it's usually just a big brain clot, right? It's most common in females, and it's very heavily related to hormones, because if you're pregnant or oral contraceptives or hypercoagulable, you're more likely to cause a clot in your brain. It can be spontaneous though, and men, obviously, in the picture, can have a cavernous venous thrombosis. Usually, these cavernous venous thromboses are only found in a MRV, or it's like an MRI, but it's a venous study. And this is something that you have to kind of have a high suspicion for because they're very rare. And that means that they're hard to find because you'll usually only find one or two in your whole career. That said, we treat these by giving these people anticoagulation, and we have neurosurgery involved because sometimes they have to go in and pull out the clot. We get very particularly worried about these patients because if the clots get too big, it can actually push on the pituitary gland, which sits right in the middle of it, and it can cause all these kind of endocrine symptoms. So one of the things that we always look out for in women is like sort of endocrine symptoms, especially right after childbirth. So this is a picture of exactly where that cavernous sinus thrombosis is located inside your brain. And you can see all of the signs and symptoms are the ones that we just talked about, some sort of neuro finding, or you can also have people who have had abscesses or dental infections, that kind of stuff on their face, and that can lead to a thrombus. All right, let's do the next case. All right, so hopefully not quite as tricky as the last case, but we have a female who basically has neck pain and a headache. So those two go together. They've been ongoing for about 3 days, and it seems to be worse when she threw out her neck at work. So she has this like vague history of neck trauma, and she has a headache with it. And there's like a little bit of systemic symptoms of dizziness and nausea, and it's not responding to oral contraceptives. So, or I'm sorry, oral over the counter medicines, not contraceptives. So ibuprofen isn't working. So we know it's not just a regular headache. And she does have this vague symptom of this neck situation. Notice that she doesn't have any big particular neuro signs other than she has some left nystagmus present, and she sounds kind of hoarse. She says she doesn't feel one side of her face. So that is actually neuro symptoms or neuro findings. And this is a particularly vague presentation, but any kind of headache with a like light neuro symptoms and sort of a distant history of trauma, and it's never huge trauma, it's like a little tiny MVC, or like somebody who's doing an exercise, it's going to be a carotid artery dissection. So carotid artery dissections are often very, very hard to find because, again, they're so subtle. It's going to be very subtle neck pain. It's going to be very subtle headache. Think about small car accidents. Think about people who are doing abnormal exercises. And you also want to kind of be noticing things like Horner syndrome, which hopefully you've watched the video on, but you can see the picture here is one pupil is a little bit smaller than the other, and then the person has ptosis. So ptosis means that what you're looking at here is the eyelid is almost touching the pupil on one side and not touching the pupil on the other side. So this can be really easy to see in young patients, and ptosis is really hard to find in elderly patients who may have wrinkles. Some of their face may be asymmetric. So always look to see if one eyelid is touching the pupil and then the other side is not. So it's not the iris, not the colored part, but the pupil. That's really what helps you determine ptosis or not. But this is a carotid artery dissection. Again, this is a little bit rare. It's really interesting to be able to find. You need to diagnose it with a CTA or a CT angiogram. And you can have a carotid dissection, but you can also have a vertebral dissection. And so in this chart here, I've located a little bit of differences. Notice that one seems to be more common in women and one is more common in men. We see that the treatment of these are actually just an aspirin daily. And a lot of times neurosurgery will not repair these because some of them just clot off and then you just have one side and not the other. So definitely be aware of this. Again, this is a lot more rare than a lot of the other headaches that we've talked about today. Let's go ahead and get to this one. So again, we have a headache, but we have a tired tongue. What exactly is that, right? That's kind of a weird description. But one of the key findings here is that she has this tingling in her jaw and also in her legs. So tingling in jaw and legs, especially when we talk about headache. And one of the gimmies here is that her past medical history is polymyalgia rheumatica. So every time you see that, I always think temporal arteritis. Get an ESR because your ESR is going to be high. And you want to look for that new headache, jaw claudication, and temporal or scalp tenderness. Now, remember that in real life, people with a headache, you're gonna touch their temple and they're gonna say, ouch, that hurts. So even though everybody always teaches you to think of temporal arteritis or giant cell arteritis as scalp tenderness, think of it actually as jaw claudication, which is that tingling or spasming jaw. And it's usually going to be just on one side. They may already have blurry vision because eventually temporal arteritis causes blindness on one side. That's why we have to know it. And you also want to get that ESR because that's going to be high. So I've listed this again for you, but it is a vasculitis rather than a headache. And you want to treat this with high dose prednisone, and you probably want to admit them. So neuro would be very thrilled if you call them with a real temporal arteritis. Again, this is pretty rare. Let's go on to another case. Okay, so we already have a warning sign where she has a headache that is different than her previous headaches. She also is having double vision and she has changes with position. Remember how I talked about changes with position being problems with the intracranial pressure? That should always be a tip off that something's going on. And then we have somebody where she's obese and she's having 6th nerve palsy. So 6th nerve palsy can cause double vision. So maybe that's why she's having an issue, right? So um, if we hadn't seen that on exam, if we hadn't seen a sixth nerve palsy, I would start thinking that double vision could be something like myasthenia gravis, right? But the fact that she has a sixth nerve palsy, that's not myasthenia gravis. And the fact that she's obese and having eye signs, I'm thinking maybe something like pseudotumor or intracranial hypertension, right? And so, of course, we're going to get a CT, which is normal. And oh, look, there's the quintessential papilledema. So it is pseudotumor cerebri, which is what I learned it as, or idiopathic intracranial hypertension, IIH. I'm not sure why they have to change the names of things to make it even harder to say, but we always want to look at changes in position being a problem of too much CSF. That's what's happening here. And usually this is diagnosed first and foremost by a LP with a really high opening pressure. So just like all of the things that we learned about in compartment syndrome, eye pressures, and CSF, almost all pressures are going to be under 20. That's what normal is. That's true for eye, it's true for compartment syndrome, and it's true for CSF. So if we have an opening pressure that's over 25, or albeit 35, we probably have pseudotumor. Most of these women are young. Most of them are obese. A lot of times they will complain about double vision, or they'll have some sort of palsy because the fluid is pushing on that nerve, causing that blurry vision. And you can see here that the way we treat it is we actually drain off some of the fluids. Sometimes they'll have it bad enough that they'll get a VP shunt placed, just like the hydrocephalus folks do. And at the very least, you can always give acetazolamide, which lowers the CSF production, and that will help some of their symptoms as well. Almost all of these patients, at least if you're initially diagnosing them and they've never been diagnosed before, need a neuroconsult. However, if they've been diagnosed and they come in with another headache, just like the paracentesis folks with liver cirrhosis, they can just get therapeutic taps scheduled with IR. So they don't need to be coming into the ER to get these drained all the time. Something to note. And finally, we have our post-LP headache. So we have intracranial hypotension. So that means that they have too low of CSF pressure. This is usually classically within 24 to 48 hours after the LP. And it's always usually due to either poor technique or the fact that the CSF kept draining out of the hole after the LP. So sometimes that has to do with the fact that the bevel wasn't up, or the fact that they didn't stay laying flat after you did the LP, or whoever did the LP. The very first criteria that you should use for a post-LP headache is IV caffeine. Again, just like concussion syndromes, IV caffeine is going to be one of the ways that we increase our intracranial hypotension. So we want to use that IV caffeine to very first choice. If that's not working, then they do something called a blood patch. And that's what you're seeing in this picture below. They actually take some blood out of their arm and they put it in a syringe, and they're injecting it in that same area around the LP. So that way there's a big clot of their own blood there, which will then hopefully heal and close off that CSF leak. And that's how a blood patch will fix an LP headache. Now, remember that we're not doing that blood patch. That's usually anesthesia or IR, but you can consult them from the ER in some ERs, or you can transfer them to a facility that will do it. Now we get into some infectious causes of headaches. And the big one, the elephant in the room, is going to be meningitis. So I'm sure that this is something that's been covered for you in school before. I'm sure this is not something that you have, it's like brand new that you've never heard of. So think of it as a migraine with flu symptoms. Also, we want to be aware of meningismus symptoms. So those are the Koenig sign and the Brudzinski sign. I can't say those very good. I'm sorry. So pretty much all of these are going to be indicating meningeal irritation. So if you flex their neck, which is messing with the meningitis, like it's messing with the meninges, and it's also changing the intracranial hypertension, they're going to flex their knees because that's going to relieve the pressure of the dura that's connected to the head and the spinal cord. So literally you're just stretching it and seeing if they can handle the stretch. And then the next is the Koenig sign, and you like flex the knee and you move it back and forth, which is also stretching the bottom part of the meninges, or the area that's attached to the spinal cord, and it's kind of pulling on it and seeing if they can handle it or not. Meningitis is usually a little bit subtle, usually is associated with some altered mental status and a fever. Usually this is a little bit overt. Usually it's obvious. This isn't like a very subtle thing, except in kids. Kids is really hard to tell because you don't know what altered mental status is in those kids. Here is a list of all of the most common bacterial items. Know that you can have viral meningitis. As a matter of fact, that is a topic of conversation right now going on with COVID. And I think it was the cause of some of the strange symptoms that we have. But viral meningitis is not something that we can currently fix, no matter what kind of viral meningitis it is. So I'm going to stay focused on the bacterial meningitis, at least for the ER, because bacterial meningitis is really something that can kill you within about 6 hours. So the reason why we care about the most common organisms in the different age groups, and the reason why people like to test on it, is because it's what's determining what antibiotics we can use. And so that's why you should know, okay, I'm suspicious of meningitis in this age range. These are the meds I need to use. These haven't changed in a good 20 years. So they're always fair game on tests. Please, please, please give these antibiotics before you do an LP, before you do a CT, and before you get lab work back. If you're that suspicious of meningitis, I would rather you give the antibiotics first. We don't care about cultures. We don't care about the CT or the LP. We want to get these antibiotics on board, save a life, okay? The other part of this that we don't talk about very often is the actual giving of the antibiotics. So giving these antibiotics isn't enough. You also need to give these antibiotics with steroids. Why? Because steroids are going to help these antibiotics get through the blood-brain barrier and get into the brain faster. This is, again, something that's weird that nobody talks about, but you need to be giving steroids. I don't care what kind of diabetes these people have. You give them a dose of steroids with this antibiotic. Again, that's before the LP, it's before the CT, it's even before labs come back. Okay? So we want to treat meningitis early. Now we finally get into talking really quickly about overordering. This is something that I've talked to many of you guys about already, and I hope to continue talking about overordering, but specifically in headaches with CTs, this has actually become a national issue, not just for you guys, but for everybody. In ERs, overutilization of CT scanning of somebody with a headache has actually led to really increased costs. And there is some hospital metrics that are put out federally called MIPS. If you haven't heard of it, you will soon. All of that said is that they don't want you to order a head CT with every single patient who has a headache. We've already talked about this earlier in the lecture, but I'm reiterating it because unless they have one of these criteria, your hospital won't get paid for that head CT. And therefore, you're going to be tracked on how often you order these head CTs. We are already. And if you're ordering them abnormally, then your hospital ends up spending a lot of money and they don't get reimbursed for it. And this is how people get in trouble. Let me just say that. So you want to pay attention to the things that I've put in blue. So if you have a trauma, you want to do a CT scan, that's okay. If you have an abnormal neuro finding, right, that's a big red flag, that's okay to do a CT scan. If you have somebody with a VP shunt, they're way more likely to have something going wrong intracranially. So of course you need to order a head CT, right? That VP shunt could be blocked for all we know. So those are really good indications to order a head CT. But I also want you to know that if it's just a regular old headache that just didn't respond to your meds, or maybe you haven't even given the meds yet, don't you dare order that head CT, right? You have to document one of these things. Otherwise, the hospital does not get reimbursed for that CT scan. The other thing that I want to point out to you is that one CT scan equals about 200 chest x-rays. This is important when I'm talking to my parents of pediatric patients about head CTs. So we don't do a bunch of lab work on pediatric patients, just like we don't do a bunch of head scans on pediatric patients if we don't need to. Because before puberty, if we're giving somebody 200 x-rays, that's actually increasing their chance of cancer later in life by about 5%. Some people say 2%, some people say 7%. I average them to be about 5%. Now, 5% is relatively low, but it is still a risk. So before I had CT, a kid that I don't think really needs a CT, especially if they're puberty or below, I always talk to parents and make sure that they're aware that, hey, there is a 5% increase of cancer later in life. Are you sure you want me to do the CT scan? That way they understand that there is some risk with the scans, and a lot of parents will then be like, you know what, actually, I'm okay not doing it. All right, let's do a quick summary and then we'll be all done. Sorry about the length of this particular one. So I want to make sure to reiterate that you know what the red flag symptoms are of your CTs or of your headaches, because you need to CT the red flag patients, right? So you can either refer to Snoop or you can definitely refer to this list on the side. Don't forget about those anticoagulation patients or the pregnant or immunocompromised, AKA the HIV patients, right? They always need CTs. Here's a list of the most dangerous headaches, and it's a differential list for you. Notice that I didn't talk very extensively on things like carbon monoxide toxicity or dental infection, right? Even though infection can cause things like cavernous venous thrombosis, the most common cause of a brain abscess is actually dental abscess that goes into the brain. It's really common and super easy if we don't treat those dental infections. However, we're going to talk a lot about that in other sections. So I just wanted to give you a list so you had something with a differential of the most dangerous headaches that we look for in the ER. I also added this blue box here in case it's just a primary headache that you should know about the locations of those headaches because they're very highly tested. Now, finally, I'm reviewing what you need to do with headache. So do you really need to get that CT scan? Remember to talk to pediatric patients and parents about whether or not they need that CT scan. You only want to do that CT scan if it's warranted, right? Based on the MIPS. So you want it to either be a trauma, they have a meningitis sign, right? Or like you're about to do an LP, or they have a neuro sign. Remember that the CT scan is best within the first 6 hours for those brain bleeds. Now we get a CTA if we're looking for somebody with a dissection or clot of the neck, right? So we want to look at those neck pain trauma patients. We want to remember about like ptosis or onset, that kind of stuff. Now, LPs, remember that we don't LP as much for brain bleeds for sudden headaches because those CT scans are so good at brain bleeds. So we're relying on doing LPs more for papilledema for our pseudotumor cerebri patients, or we're doing LP for our meningitis patients. So people with fever and meningeal signs, right? And then we only get labs on our headache patients because even if they have a brain bleed, it's not going to show up in the labs, right? So we're only getting labs for our toxicology patients, our patients with a fever that we're thinking is some kind of infectious etiology, or for our pregnant patients. You might be able to add anticoagulation here to see if their INR is way too high. That's also another option. And then, of course, MRI or MRV is we're looking for either stroke-like symptoms. So
We didn't really talk about this today, but a stroke isn't always seen in a CT scan. Sometimes it takes an MRI to see a particularly small, tiny stroke. So you'll see a lot of neurology admitting stroke-like symptoms to get an MRI to rule out stroke. But the other part of this for the emergency department is that cavernous venous thrombosis, that MRV. So especially if you're thinking about it, it's not maybe something that you need to stay in the ER for, but it might be something that you need to be admitted for an MRV. And then finally, when do we consult neuro? And it's really all about, hey, I've tried everything to help this patient's headache and it's still happening. It's still intractable. I need your help. That is a really good time to consult neuro, or if they have unexplained neuro symptoms and their workup is completely negative. So hopefully you're not contacting neuro first thing when you get a headache patient, and hopefully you're not ordering a CT scan in every headache patient. Finally, I just wanted to review the useful headache medicines for primary headaches. Excuse me. Remember that Toradol with Compazine and Decadron are 3 really good medicines to use in combination as your primary headache cocktail. Remember that you don't need to give Benadryl, you don't need to give IV fluids, and do not give opiates, please, please, please. If you get stuck in a pinch and they're still having a headache, consider giving that magnesium or caffeine. And remember that sumatriptan is definitely acceptable and usable within the first 6 hours. But if it's after the first 6 hours, it's probably not going to make a difference. So don't waste your time or their money, right? And that's it. Definitely let me know in the comments section if you have any questions, or you can definitely always email me. And I guess I'll see you next time.